Thank you so much, madam, for such a wonderful presidential address. With this, who started with the idea of e-Gurukul, our program in charge, Dr. Yogesh Parikh sir. I welcome Yogesh Parikh sir for his words of wisdom.
Yeah. Thank you, madam. Yeah, I'm in the other meeting. Please go ahead. Best wishes and congratulations to team AOP Gujarat.
Thank you. Thank you so much, sir, for the wonderful wishes. As our team is progressing, we have the zonal coordinator. So I welcome Dr. Shwetal madam and the main coordinator of this program, Dr. Lata. So I'm handling this platform to Dr. Lata. Please introduce today's mentor, presenter, and our expert.
Good evening, everyone. Thanks, Nehal ma'am, for your kind words. Thanks, Jhankhana ma'am. Today's hero is, I'll say heroine, basically, Dr. Hardee Shah. She's third year resident of Pramukhswami Medical College and Shree Krishna Hospital, Karamsad. We have Dr. Bhavdeep Mungala, Assistant Professor of Department of Pediatrics from the same college as the mentor. And expert for today is Dr. A. Prakash Amboiram, sir, who is Professor in Neonatology and Senior Consultant at SRIH HER Sri Ramachandra Medical Center, Porur. Welcome everyone, and I hope today's discussion will be really entertaining one.
Thank you, Lata. Thank you so much for the wonderful coordination and today's introduction. A man who doesn't need any instruction, and the Gurukul PATHSHALA is known by him also. So I welcome our mentor, Dr. Baldev Prajapati sir. Sir, the platform is all yours.
Good evening, friends. Thank you very much, all of you, for taking so much, I will say, pain and efforts for establishing this type of the academic sessions. Let me declare my clarity that I am general pediatrician, not really expert in the neonatology. So many other, I will say, friends I am able to see on the screen. Those probably are focusing on the practice of neonatology. So I request them that please, even you participate in the discussion, give even some very specific aspect of the discussion, so that probably not only the students, but all of us can learn. And we know that always best learning is from the discussion. So I hope that with these ideas, and as Dr. Jhankhana madam said, our aim of case discussion is not very specific diagnosis. Our thought process. From these very specific problems or the complaints, what you are thinking, how you are analyzing, and how one is correlating to consider some possibilities. And I think gradually I have learned that it is the best method of thought process in the medicine. It works very well. So with that introduction and ideas, I request, I think what Madam said, Dr. Hardee Shah is the presenter, am I right? So I think, I'm not sure, Dr. Hardee, he or she, really I'm extremely sorry.
She's.
Okay, she. So Dr. Hardee, I think you can share the screen and start your PPT presentation with the history part. Dr. Hardee, please. Fine.
Good evening, everyone. I am Dr. Hardee Shah, third year resident at Karamsad Medical College. I am here to present a newborn case presentation under guidance of Dr. Purivan, our HOD, and Dr. Bhavdeep.
Excuse me, Hardee.
So my
You
case,
you put your
yes, sir.
Hardee.
Yes,
You
ma'am.
put your video on. Video on.
Okay.
Is it okay for you to put your video on?
Yes, ma'am.
You are not visible. Make it visible. Okay, now nice. Sorry for disturbing. Carry on.
My case is the baby of XYZ, a 47-day-old male neonate, third born of non-consanguineous marriage, born at 27.5 weeks of gestation as per first trimester USG, that is post-menstrual age of 34.4 days. Born via vaginal delivery at Shree Krishna Hospital at 8:49 p.m. On of January 2026 with birth weight of 968 grams. Admitted in NICU for prematurity and respiratory distress. Informant is mother and seems reliable. So antenatal history, mother is 32 years old, married at the age of 19 years with active married life of 13 years. Mother is third gravida, third para, and has two previous live children. This pregnancy was a spontaneous conception, which was diagnosed by urinary pregnancy test at government hospital. The LMP according to mother was 9/8/2025 and the EDD was 16/5/2026. So pre-pregnancy weight for mother was 50 kgs and BMI was 21 kg per meter. Mother's blood group is AB positive. There is no history of any thyroid disorder, any diabetes, or any other known disease or ongoing medication to the mother. In first trimester, mother was registered with
I think Dr. Hardee, can you stop sharing for a while?
Yes, sir.
The reason is probably what information you have provided. Let us discuss. Otherwise, what will happen that most of us will forget it and difficult to recollect. So let us try to understand this, whatever the information already you have presented. And again, I request all the students that please participate in the discussion and keep your video on. Hardee, I think you can help me to identify some of your colleagues, those who must be on the screen. Probably later on they may create the problem with you, but at least you can help me. Right. Can you help who are there on the screen? Some of the students from your institution?
We have Dr. Ria.
Sorry, some of your...
Dr. Ria, Dr. Kalpesh,
Dr. Ria.
Dr. Twinkle.
Dr. Twinkle. I think last time also they were there in the OSCE.
Yes, sir.
Yeah. Anyway, what I wish and again request all the students that you should participate in the discussion so that all of us can, anyone that will be maximum benefited to you. My first question, very simple. As I said, I am general pediatrician and many a times in the exam also, they will start with the very basics. If you are good, then probably they may change some set of questions. What is the definition of this neonate? Very simple question. Hardee, I think let others answer. You must be prepared. Yes, anybody? Very simple question. I think not many answers should be there immediately. Dr. Rian, because some of your names already Dr. Hardee has mentioned. Ria, are you there?
Make yourself unmute, Ria.
Please. I think Dr. Bhavdeep will help me.
Sir.
Yeah.
Sir, from birth till 28 days, sir. That is called neonate.
Okay. Now the next question, please you continue to respond. Here she said that the 47 days old male child. and simultaneously she has used the adjective neonate. Do you agree with her, Priya? Or because you are a friend, you will have to agree?
Yes, sir.
Please
Riya,
to
what is
answer.
Riya, what is your answer?
Yes, I agree with her, sir.
Because already you said up to 28 days it is called as neonate. And here she mentioned that here the child was 47 days old. And she had mentioned neonate. Is it the right presentation? Do you agree or don't agree? And then what will be your response? Because already you said 28 days old baby is neonate. Beyond that, you don't call them the neonate. Anybody else? Dr. Twinkle?
Other can also answer, Dr. Parth.
Anybody, please. On the contrary, multiple answers should be there, and that will probably create more clarity. In the exam, suppose somebody is asking, you will be more clear. And as I said, even I may not be suppose clear, I will take the help of the other experts. Dr. Bhavdeep is there, Dr. Shwetal is there. I know exclusively, even Dr. Kritika, probably they are more working in this neonatology. Dr. Purvi is there, yes, I know all these teachers. So they will guide us.
Rather than writing in the comment, please participate directly.
Yeah. Dr. Bhavdeep is, I will say, motivating. That's good.
Yes, sir. We can say that neonate because patient is not discharged from the NICU, sir.
Okay.
This is my opinion particularly, sir.
Okay. So Dr. Sandeep Trivedi, all of you must be knowing, senior pediatrician practicing. Hardee, he's there to help you. He considers that, yes, sir, she's right. Right. Okay.
Second thing, sir, I would suggest as patient is extreme preterm. So according to corrected gestational age, still is in neonate period.
Yeah, exactly. I think that answer should be there. That as we define these 28 days, but here the baby was, I will say, quite preterm. And if you go for corrected age, probably still must be following in this category. And that's why you say. So Hardee, your answer should be like this. That by definition is 28 days. The definition we cannot change. But here still 47 days I use the term neonate due to the very specific situation. And I'm sure that is convincing. These types of questions are going to be there. Okay, number one. Second, she said, non-consanguineous marriage. What is the importance of mentioning over here? How it is relevant in this neonate history to mention that there is no consanguineous marriage? Hardee, your response I will take last because naturally you must be ready, prepared person. Let me interact with other students. Anybody?
So Dr. Twinkle, please answer this.
Yeah, I think Dr. Bhavdeep will have to identify the students because I may not be knowing everybody.
Yes, sir. Yes, sir. I will direct it.
Yeah, and you can motivate them even. Here yes. I will say we are here to motivate you, to encourage you. So please try to answer.
Give your answer. That is doesn't matter it is right or wrong. Give your answer. This is not exam.
सर कॉन्स्टिट्यूशन के अंदर ऐसा हो सकता है कि कोई स्पेशल कम्युनिटी में कोई डिजीज होता है लाइक अगर कोई एग्जांपल के तौर पे थैलेसेमिया
Dr. Raju, sorry, some of your voice is not clear. Can you speak it clearly and slowly so that we can follow you, please?
Sir, can I?
Yes, now it is better.
ऐसा होता है कि कोई कम्युनिटी में स्पेशली लाइक कोई थैलेसेमिया जैसा रोग है या फिर कोई ऊपर से जेनेटिक में आता है लाइक Muslim community में थैलेसेमिया.
I think you know that suppose somebody is from even the Kerala or Tamil, the person may not be knowing the good Hindi. Right? Some examiner, you know that now examiners are from different corners of the country. Again, that's why I want to encourage that your answer should be as far as possible in English. Even in your daily round also, it helps us a lot. Yes, what is your answer for the non-consanguineous marriage. What do you mean by the consanguinity?
There is some specific disease that transfer in a specific community. Like in Kutch region, there are the Muslim community, there is thalassemia band here.
No, that effect we'll learn later on. First, we want the definition that what we mean by the consanguinity.
Interfamily marriage.
Dr. Hardee?
So marriage within first or second
Degree.
You know, the degree will come later on. Right? That at what level in the relations the marriage has taken place. Accordingly, we'll try to go for the grading or the degree. And that also, what is your idea of going for the grading or degree? You know, the point is why I'm asking this question of consanguinity. Why I'm giving so much importance. That's the thing. So first we'll have to understand that what exactly we mean by it, and therefore medical definition. Relationship or marriage in the nearby relatives is I will say just a lay definition. But exactly what we define. Anybody?
Blood-related disorder, blood-related relation.
Dr. Suresh, I told the same thing, that this is the lay person's understanding, and you are right. But I want the medical definition. And you know, from us, it is expected. Reason is, you know, we want to define the meaning of it. Hardee, you have any idea?
They have common ancestors. So,
right.
Some diseases.
You have some idea, I understand. But up to what common ancestor? Please understand that marriage, here consanguinity is defined as the marriage taken between two persons. Those have at least one common ancestor, not beyond great-great-grandparents. Up to that level we consider. Because in the science, in the genetic study, it is studied that to this level, genetic sharing is playing the role for transmission of some specific diseases. And for this reason, they have defined. I will say roughly, if you see, it comes to the third generation. And then we go for the degree. Because first degree, more sharing of the genetic material, about probably 50%. Second degree may be the 25. Third degree may be the 12.5. And according to the sharing of the genetic material and possibility of the disease. You know, that's why we are very keen to know exactly the consanguinity in our medical science. And please, somebody is going to ask the question once you mention regarding these things. Okay, that's good that you have mentioned the blood group of the mother also. Even in the sometimes the practice, I see that people don't bother to know the group of the mother. Later on, the problems can start. And so here, just I want to sensitize the students. Somebody may focus on some questions of blood group, incompatibility and problems in the baby and everything you should know. Anyway, so I think we...
question related to...
Yes, sir. I think Dr. Prakash, I know your presence. And please, you can add when probably we have stopped to our general level. You can add some of the points, please.
Yeah, that's right. So why is it only till grade for the means? Because beyond that, the gene sharing will be 6.25, which is same as general population risk.
Right.
So that's why they don't take beyond that.
Yeah.
Second is, what kind of diseases are common? What type of inheritance do they have in consanguinity? Can people answer that? And what is the chance of a disease in a consanguinely married couple?
Right. So I think very good point, even Dr. Prakash further added, that in general population, usually the sharing of the genetic material beyond the consanguinity will be less than 6.5. And therefore, we don't give the much importance. But yes, that thing is known. Okay, thank you very much. Anybody else even want to say something, Dr. Shwetal or Dr. Kritika or Urvi or anybody, please? those who teachers are there on the screen.
Yes, we can also define, sir. It's okay. Sir, you can continue.
No. Sorry, I asked two questions.
Yes.
Whether it was understood. I just wanted to know what kind of, this is genetic disease they develop. What is the inheritance among consanguineous marriage? And what is this percentage of, the chance for developing the disease?
Yeah. Dr. Prakash, Hardee wants to know that what are the specific diseases which are having this inheritance with these consanguineous marriages. Can you give some example?
Dr. Pankaj Haini.
Autosomal recessive diseases.
Dr. Manjusha, please mute yourself. Dr. Manjusha Lal, please. Yes, Hardee, please continue.
Sir, autosomal recessive disease.
Right. Can you give some common examples?
Now, first tell me what is the type of inheritance among consanguineous married couple? What are the type of inherited genetic disease you get? What is the type of inheritance? Like right? It is autosomal dominant. Autosomal.
Yeah, she said autosomal recessive.
Autosomal recessive.
Yeah, she mentioned.
Okay, you have told that. Sorry,
yeah,
I could not hear. Oh, okay, good.
Yeah.
Yeah, now tell me for every pregnant, what is the chance of developing the baby developing a specific autosomal recessive disease in a couple who consanguineously married?
Sir, if mother and father both are carriers, then there is 25. If the disease had.
Yeah, you are right. You go on. Yeah, you are right.
50.
So 25%. Please remember for every pregnancy.
Chance 25%
not that one
can
baby.
Be normal.
Yeah, correct. But remember, it's in every pregnancy.
It's
not that one baby is affected, the next 3 babies will be normal. It's not like that.
Yeah.
Okay, so it is every pregnancy you have 25% risk.
I think this clarity is definitely required even among us also, what Dr. Prakash made. And even the lay persons always they understand in this way. 25%, that means suppose already my one baby is affected. So rest of the baby is going to be normal because already 25. So if I have the 4 children, one is going to be affected. So already one child is suffering from the disease. So from next pregnancy, I am safe. They will be interpreting like, and sometimes to the medical people. So what sir wants to make the clarify, and genetic counseling now, that is another thing. I will say this is not just passing the exam. We'll have to translate it in our daily practice also, and that is lacking. That's why I think we want to go for all these clarifications. And now you know that genetic is as a whole different, very fast developing specialty. And as a general pediatrician, if you don't know the much details, okay, but general principles, we should be aware of it. And therefore, we can say that autosomal recessive is only 25% possibility of affection of the baby with each pregnancy. So every time they should keep in mind, right? So I think that good question. And similarly, they can go for a lot many questions in the genetic. Autosomal dominant, what you mean, X-link, and then what are some I will say common examples. So everything is very important. I think before we go further, Dr. Shwetal had some question. Madam, are you there?
Yes, sir. Yes, sir. No, sir, no question. Just wanted to add that she can also explain in the form of degree charting, first degree, second degree. Just to add it, nothing else.
Yes. Fine.
Yeah, that will be easier for them.
Absolutely. Okay, I think now, Dr. Hardee, you can take the story further, history part.
In first trimester, mother was a registered case of General Hospital Anand, and with total antenatal visits taken were 8. Folic acid supplementary.
Actually, sorry, Dr. Hardee. Dr. Hardee, nice you are presenting. But generally, we need to first a clinician would like to know why is this case being presented. So that is not come across. This is a 27-weeker and already now almost 32 weeks or so.
Why are you presenting this? What are the present? Just list a small, problems now,
What are the
and then you
problems or
start from first
complaints?
trimester.
Yes.
Because otherwise, I will, as a clinician, I would not know what are you questions you're going to ask or what are you going to present.
What is your interest of presentation?
So the patient was admitted for prematurity and respiratory distress in our NICU, and now he's 47 days of life with PMA of 34.4 with being cared for prematurity. So he's
Okay,
a
it's
growing
a growing preterm, not on any respiratory problem. It is just a growing baby. So you don't have to really, understood. Okay, right. Now you can go on. Now I have an idea what are you presenting.
I think, Hardee, even you can take it some other way also. If somebody asks this question that why you are presenting this case, you can say that the baby was so preterm, birth weight was only 968 grams, right? And with that prematurity, with even the problems of premature, we could manage. And we thought that let us share this information with these pediatricians or friends. And that's why I have selected this case to discuss. Suppose nothing is very specific, you can take in that way also. But that is very important what Dr. Prakash has mentioned, that even in CNS and other cases also it happens so that suppose thalassemia, cerebral palsy, DMD, all are the, I will say, known conditions. And then why during the exam time you are presenting? That question is going to be there. May not be sometimes any specific problem or complication with the patient. So you can say that what was our idea of presentation or discussion? Okay. But these questions are going to be there. Please take it further.
Okay, sir. Folic acid supplementation was started. Mother tested negative for HIV, HbSAg, and VDRS. Mother's HB was 11 gram%. First dating scan was done at second 2 months of amenorrhea on 9/10/25, which was suggestive of antenatal fetal age of 11 weeks 5 days. There was no history of excessive vomiting, fever with rash, or any other medications or drug being taken, and there was no history of radiation exposure. In second trimester, 2 doses of TD vaccination was given at second and third month of gestation with a gap of 4 weeks. Iron and calcium supplementation was started. Second trimester USG scan was done on which was normal, that was explained to the mother. Mother felt quickening in 5 months of amenorrhea. There was no history of pregnancy-induced hypertension, gestational diabetes. There was no history of hypothyroidism. There was no history of spotting per vagina. There was no history of blood transfusion or need of any hospitalization. In third trimester, mother continued to possess fetal movements till the start of 7 months. Weight gain of mother during pregnancy was 5 kg. There was no history of fever or burning menstruation, conversion. There is no history of foul smelling discharge or leaking PV or any abdominal pain up till now.
Okay, can you stop sharing? I
Yes.
think can you stop sharing because the antenatal part we'll first discuss.
Yes, sir.
I think I will request Dr. Prakash to take this discussion for the antenatal history with other students and Dr. Hardee.
No.
Dr. Prakash, can you take it?
Yes, I was thinking somebody is also asking. Yeah, okay.
Sandeep, mute yourself. Dr. Sandeep.
Yeah, thank you. Now, say Dr. Hardee, when you are taking the history of antenatal, can you highlight the importance of getting first trimester history in this baby, in relation to this baby, which will be useful in a clinical management?
So in first trimester, first we have to ask for last menstrual LMP, so that
Why you want to know that?
So we can calculate the EDD also, but also to know the gestational age of the baby.
Very good. So what is the best method to know the gestational age? If you're given, what are the ways you will estimate and what you think is the best method?
The best method is first trimester dating scan,
Excellent.
which will tell us the most accurate gestational age. There we can
Excellent.
do Ballard within 24 hours of birth, and if there is a variation between Ballard and LMP of more than 14 days, we consider Ballard over LMP.
Okay, right. So why you think is important to know the gestation age?
So there are different problems that we see depending on the maturity. In preterms, extreme preterms, we have issues like respiratory distress, there is IVH, there is NEC. In late preterms or in summer babies, we see TPN or such issues.
Right, good. So it's important that you know the history because certain things are high risk. Like for example, IVH is more common in less than 30 weeks. And also, do you know the classification of premature babies? How do you classify a preterm baby?
So less than 28 weeks is extreme preterm. Then from 28 to 31 is early preterm. From 31.6 is still early preterm. From 32 to 34.6 is late preterm and moderate preterm.
Moderate.
And from yes, and from 34.6 to 37 is late preterm, and from 37 to
Excellent. So now, what is the mother's age, and anything significantly you will ask in the first trimester? What is the mother's age?
The mother's age is 32 years at present.
Yes.
But the
so what first trimester would? Yeah, please go on.
The mother conceived at 32 years of age, and I have asked active marriage life of 13 years. So if there is very long active married life without conception, it can give us the history of infertility or any such issues.
Okay, that's fine. So now they have become pregnant, so we are not too worried about the infertility, right? So in a baby, a mother comes to you at 30 years and beyond, and they conceive, they're asking you to, suggest something in the first trimester. What is one important testing you will do in the first trimester? And for what do you do that?
So for mothers with older age, there are high risk of anomalous babies, mostly Down syndrome. So we have to scan for that. We'll do PAPP and beta HCG levels, and we'll also use the USG to look for knuckle translucency or nasal bone.
Okay, good. So you look for what do you call that as? First trimester screening.
Yes.
Right, and then you will lay some that. Okay, now we are just, I think, and then we'll come to the second trimester. What important history you would like to elicit in the second trimester?
So if in second trimester, generally we'll ask for if there is pregnancy-induced hypertension or if there is pregnancy-induced diabetes mellitus or there is development of hypothyroidism, if there is any history of fever or history of any UTI, or there is any
history of fever is it important in the first trimester also? Why is it important? Which is important? If a mother comes and complains to you in the first trimester fever, and the mother comes and complains to you in the second trimester fever, which pregnancy you'll be worried?
I cannot hear you, sir.
No. I'm asking you if a mother comes with you with the first trimester fever, okay, and another mother comes to you with the second trimester fever, in which mother you'll be worried about the fetus?
Sir, in first trimester, because generally first trimester organomegaly happens. if any there is organogenesis, so if there is any infection, it will lead to animals.
Okay, good. So, what is the inspection termed as? Is the most important infection you look at? What is the infection that is called, to group, torch infection. Okay, right. So second trimester, yeah. So you go on second trimester, finally you look at the mother's health. Okay, and what all other things you
Yeah,
will
I think, Dr. Prakash, before you go for the first trimester, should I go for some of the points?
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
Dr. Hardee, you mentioned the folic acid supplementation.
Yes, sir.
So can you give the exact guidelines? During the pregnancy, what is the importance of folic acid supplementation?
So guidelines say that we should start folic acid before conception at least 100 days, and the dose is 400 micrograms, and after pregnancy for 100 days and throughout the pregnancy. But for if there are any high risk, if there is any history of previous neural tube defect or any such thing, that we give dose of 4 grams 100 days before throughout the pregnancy and baby, to prevent a subsequent neural tube defect.
Sorry, what dose did you say?
So we give 5 total 4 mg folic acid if there is history of neural tube defect in the previous baby.
Roughly, you can remember that the 0.4 milligram in routine, I will say, even any pregnant or expectant lady, and 4 milligrams, suppose there is history of already one child is suffering from the neural tube defect. But this is very important, and we should not miss it. It is at least scientifically proved that it's a very good measure for prevention of neural tube defects. That's why its importance is there, and we should convey the message. Second thing, regarding the pregnancy, you said that the injection TD was given. So, but suppose some mother asks you that I have heard that even better this vaccine than some other vaccine is available, I don't mind to pay for that, then what will you advise her?
So we give Tdap if that is preferable over TD now.
Why Tdap is preferred?
So it will prevent, it also has the pertussis component, so it will prevent pertussis in the baby until we are giving PPT.
How it will be able to prevent the pertussis to the baby?
Because there will be from mother to baby there will be pertussis antibodies that are formed in the mother that will cross over to the baby.
Why you are worrying so much for the pertussis in the newborn? Because other diseases are also going to develop. Somehow we are not concerned much. Ideally we should be. But why I will say very specific importance is given to the pertussis component to prevent the pertussis in the newborn. Why you are scared so much for the pertussis in the newborn? Why so silent?
So because it has, we have seen it being in the earlier days, and also it has high mortality.
Hardee, my question to you, and you know that is my pattern even in the exam also. I think now you said you are third-year resident in the pediatrics. Have you seen a patient of pertussis? Yes or no? Suppose if you have not seen it, you are most lucky person. Not seen. Or you have missed. That is another question. And second, have you seen the neonatal baby with a pertussis? That's good. We don't want to see. But unfortunately, we do come across. And the reason is, I think you know the problems. Once you see the neonate with the pertussis, you will realize the importance of the prevention. Because neonatal pertussis will be in a lot many problems. starting from simple feeding problem to aspiration, to even the malnutrition or not gaining weight, to even the apnea, even the seizures, occasionally deaths even, hypoxic seizures, and so many problems of neonatal pertussis. And that's why it is very important that it should be prevented. And there are very simple measure is available. So I think even IAP should recommend that instead of the TD, better you should go for the TDAP to all the mothers, pregnant mothers, not only I will say those who are able to afford. Number one, is there any other specific measure taken by some developed countries like US, wherever I would say Indian families are staying there, when the young couple, their son or daughter has newborn, they are going US for taking the care. I think this is very common scenario. All of us must have seen even in your relatives, friends, family. Is there any specific precaution recommended in this situation, or any specific vaccine is recommended for the grandparents, those who are going US or some other developed countries where their daughter is expecting this newborn? Did you get my question? Okay. Even anybody else can answer. I'm sure that you must have heard from some of your relatives that now they are going to US to look after their grandchild, which you are expecting within few days or few weeks. And for that reason, they take some vaccine over here before going to US. And that which vaccine, and again, what is the reason?
So, sir, initially, according to our government immunization schedule, all the child were immunized with the initially DPT, now pentavalence, but their antibody and efficacy is win over the 10 or 12 year of life. Then again in adult life, there is no surety of the protection against this disease. So now concept again with the adult immunization, where TDAP is recommended for the further prevention as resurgence in the adult patient also of such diseases. So when the adult is traveling from endemic countries to non-endemic countries or developed countries, it is advised TDAP vaccination. So then they will get enough antibodies that will protect the others.
So the grandparents are taking the TDAP vaccine before going to US to look after their grandchild.
Right. So that is also a part of geriatric immunization also.
Then another thing, somebody going to ask you, what type of the concept in the vaccinology we call it? Because here the child is not given the vaccine. Grandparents are given the vaccine for prevention of the disease. Then what is that concept in the immunology or vaccinology it is called? Yes, Dr. Rahul Tandon, I think probably I know ID specialist.
Sir is a special interest in vaccine, sir.
Yeah, probably I know the same Rahul should be there. In the vaccine. Anyway, that is the cocooning. When what we do, surrounding people are protected so that you're not able to transmit the infection to this particular target child or even immunocompromised person. Similarly, we do in suppose some person is suffering from malignancy, immunocompromised drugs are going on. Suppose unfortunately if some vaccines are not given and therefore vulnerable to develop this vaccine prevented diseases. To prevent this particularly, surrounding family members are given the vaccine so that they are not transmitting to the person and the person remains protected. That is cocooning concept of the vaccinology. Anyway, this because the examiner is not interested only in neonatology or particularly your newborn and prematurity. He wants to know that how much pediatrics is known to Dr. Hardee. They want to know the exactly knowledge in this pediatrics or neonatology, and therefore all these questions are going to be there. You said iron and calcium started in the second trimester. Why not in the first?
Sir, so ideally iron should be started in second trimester because it will affect with organogenesis,
Is
which
it or some other reason? Somebody says, suppose if it is, I start from the first trimester, what is wrong?
So it can be done because in government hospitals or in severely anemic mother, they do give iron from first trimester.
But I'm sure the neonatologist like Dr. Prakash will say that better to start in the second trimester, not in the first. Why?
So it can be teratogenic as well.
Yeah, they say that any drug, even they say including iron, may be the teratogenic, and therefore better to avoid. And already you answer. First trimester is the stage of organogenesis. So during the formation of structures of the organs, better to avoid these type of the insults. That is the concept for avoiding this. That is very important. I think now we can go for the second trimester. Again, Dr. Prakash should be the right person. Sir, can you take it for the second trimester? Dr. Prakash, are you there?
Yes.
Yeah. Hardee, please stop sharing. We'll first finish the discussion because, all these questions are very important to all the postgraduates. So please, you should be very, and simultaneous, I think, to the practitioners also, not only to the students. Sir, now you can focus to the second trimester. I thought some of the points are useful even from the exam point of view. So now, please, you can take second and third trimester together. Dr. Prakash. Anyway, I think whether his connection is lost or something, because already he was there. Anyway, Dr. Hardee, what are the important points in this second trimester? Suppose one important point you can mention. Sometimes, suppose your performance is good, I will change my questions. You may be knowing the very basics of the second trimester. But if I ask that a very specific point for the second trimester, which one should not miss it, tell me the only one point.
Sir, anomaly scan.
Okay, very good. And it should be done at what time?
Sir, in fifth month, 18 to 20 weeks.
Okay. Later, I think Dr. Prakash. Dr. Prakash, the
Yes, sir.
connection was lost. Therefore, I.
I'm back.
I think you can cover second and third trimester. Important
sure.
aspect, please.
Yes, sir.
Being neonatologist, you'll be the right
second
person.
trimester. So, what is the primary thing you will look at in a second trimester scan? You are given a second trimester scan. So, what are things will you look at?
Sir, we look at any second trimester scan as anomaly scan. So we mainly look for any congenital deformities which are present.
Yeah, very good. So you look for anomalies.
Structural deformities. Yes.
Why do you do it at 18 to 20 weeks? Why do you primarily concentrate on doing it at 18 to 20 weeks? Why is it not earlier or later? They primarily concentrate do it at around 18 to 20 weeks. Is there any reason for that?
Because if there is most of the organogenesis is completed by that time, and also if
excellent, okay,
we want to terminate the pregnancy, it is if there is some anomaly that needs termination.
I think you.
That's why not 24 weeks? That was the question from sir. Probably 12 weeks, okay, you can say it's too early. But every organ, but the next question sir is going to ask, why not 24? And for that reason, I think your answer is there. Good. Sir, take it, please.
Good. Yeah, okay. Next. Yeah, next is one is anomaly. Then what is the next thing you will look at? What are the other things you will specifically ask in the
So we look for fetal movements. We look for umbilical artery.
So basically, you can say the fetal well-being. So you may basically look at the fetal well-being.
Yes.
Right. So you look at the growth. You look at the other aspect of it, and then what will you like? When will you look at the Doppler? Do they do Doppler for all babies or any specific category of babies?
Mostly Doppler is when there are in preterms and when there are chances of IUGR, we mostly look for it.
Suppose, is it wrong to look at Doppler in an appropriately grown babies? Okay, so the answer is clear. You only if there is fetal growth. Now, IUGR terminology is also changed.
Yeah.
So they say only a fetal growth retardation. Yeah.
Yes.
So you said this thing as FGR is good. So it is fetal growth restriction is the new terminology is being used. So whenever you find there is a fetal growth, that is the time you apply Doppler. Otherwise, Doppler can be very misleading in other pregnancies. So, right. So, based on the Doppler, based on the other problems in the mother, what are the other problems you'll ask for in the second trimester, which will affect the fetus?
So if there is bleeding or there is abdominal pain or if there is any leaking PV or if there is any spotting, we'll ask for anemia and there is any history of blood transfusion or any morning micturition.
Okay. That's okay. So all those things are almost terminal events. Like most of it we may terminate pregnancy, but anything that will pregnancy there won't be a need to actually terminate pregnancy, but still it's important to know those things, which I think you said anyway. The history of what are other things and what will it affect? How does it affect the fetal growth? What are the effects of those mental conditions on the fetus? I hope you understand my question. See, the question is, what are the maternal
Dr.
conditions?
Hardee, I think sir is traveling, so his voice may not be clear. He wants that what are the maternal disorders or diseases which can affect the growth of the baby?
Yeah, correct. Yeah, growth or in affecting
growth or as a whole affect the baby.
Yes, it's correct. Exactly.
There is pregnancy-induced hypertension or the mother has
So what will
gestational
it
diabetes.
No, wait, let me just give me what happens to the baby.
What effect will be there on the baby?
Okay.
Sorry,
So
affect
if
the fetus, yes.
mother has pregnancy-induced hypertension, that it will lead to IUGR baby. If mother has diabetes, then it will lead to LGA baby. There will be congenital anomalies like congenital cardiac anomalies, renal agenesis, hip dysplasia.
So regarding the congenital anomaly and diabetes, gestational diabetes, how far it is associated with major congenital anomalies?
I could not understand.
Sir, say that suppose gestational diabetes mellitus to the mother, in what way the baby is going to be affected, particularly the major malformations?
There will be
I think Hardee, I understand this is an injustice to you because whether your friends are not answering, they are not participating. So I think Dr. Bhavdeep will have to.
So Dr. Twinkle will answer this question. So what is the specific
on the contrary,
anomaly seen in the infant of diabetic mother?
I will appreciate Hardee that even she is answering really very nicely. At the same time, others should participate. Only she is not going to present, I will say, in the exam. Everybody has to present. So I think what questions come from Dr. Prakash, other students should answer.
Twinkle, Dr. Twinkle.
Bhavdeep, Dr. Bhavdeep, you can help, please.
So Dr. Twinkle, make yourself unmute and answer. So what are the congenital anomalies seen in the infant of diabetic mother?
So specifically diabetic mothers had neural tube defects, spina bifida or hydrocephalus, mainly hydrocephalus can occur in baby. And in CVS, cough maybe occurs in baby.
What type of serious complications, congenital, specifically? This is the specific answer.
Please, I think another point, if I clarify to insist, Dr. Prakash has very specific asked a question. The mother had no diabetes before this pregnancy. It is the only gestational diabetes mellitus. How much the impact would be there on the baby, that you can ask. It is a very specific.
So I understand LGA was one, which you said gestational diabetes, LGA is one. What other complication you would expect? Say, so somebody's answered the VSD.
I think
VSD does not happen
that may not be the correct answer. I will say in the NEET particularly, where the very precise answer should be there. That what is the most common congenital heart disease in a case of infant of diabetic mother? Most common.
Most common is different, and most specific is different.
Yeah. Most common is transfusion great vessels. Most specific is different. Okay.
And what is the specific anomalies related to infant of diabetic mothers?
Yeah.
Specific.
So let me give you a hint. The baby is large. So what will happen to the heart?
Large baby, large for day.
What happens to the heart? Hypertrophy, anything? You haven't come across any baby with a IDM mother?
We are seeing routinely, ma'am.
Because nowadays the ICMR is so much worried that so many researches are going on that why these young mothers are having
even you know that is it is said that it is a transient. Later on it disappears.
Yes. You can see the chat box.
Yeah, somebody has mentioned. But I think it names come some iPhone, then Zoom user. So I think please identify yourself. Please identify yourself.
Please remove your robot name. Get actual name.
On the contrary, I will some basic thing, but let me even clarify. At anywhere in any conference or any this sort of discussion, before response, always identify yourself. That I am Dr. Prajapati, I am pediatrician, and this is my answer. Even Dr. Hardee, you can say that I am Dr. Hardee, I am third year resident. You know, therefore, even the how much expectation should be from you, that also somebody can even expect. So suppose some senior professor, then I'm expecting that how many he has really the experience. So better to, I will say, identify yourself. Anyway, Twinkle, come on to this basic question. Very rightly, already that answer is given, that usually the hypertrophy, septal hypertrophy is very common, it is transient, it will disappear.
So, shall I just summarize so that people don't go away with the wrong notion? So, diabetes prior, that is, we call it as pre-gestational diabetes. If it was there and not controlled, will lead on to congenital anomalies because this hyperglycemia will affect the organogenesis and cause cardiac disease. And somebody has written caudal regulation syndrome. That's very nice. So all that will be, there are a lot of other congenital anomalies which can happen in a gestation diabetes mother. Now, in a pre-gestation diabetes mother. Now, in gestational diabetes, which usually is onset is in the second or third trimester, where organogenesis is already completed. So there won't be any major congenital anomaly related to the gestation diabetes. But it can lead on to metabolic conditions like hypoglycemia, hypocalcemia, and things like that. And also all of you have written asymmetric septal hypertrophy. The insulin is an hormone.
Please mute yourself. Somebody with the iPhone. Lata, I think you can manage.
Somebody on the iPhone.
Yes, sir, I will message him. I'll message him.
Yeah. Everybody has iPhone.
I think the host can actually mute the phone. I think the
host can do.
Host will have the right to mute the. I'm not able to mute.
Lata, I think you can request the host.
Hardee is host. Bhavdeep sir, you are also co-host. Either Hardee, you make Lata host.
Yeah.
Yeah.
So
Okay.
I just made
Fine.
iPhone mute.
Anyway, it is managed ultimately. You know, we are learning so many things to manage.
Emergency in emergencies right now. Digital emergency.
Yes.
Thank you, Dr. Prakash. I think you are traveling, but still taking, I will say, good points. Please complete your points. Please.
So what happens is that the heart has got special receptors for insulin, so they cause deposition of the glycogen in the heart also. So they will have hypertrophy of the heart. So it's not classically I know what we call as dilated cardiomyopathy or anything. It's actually called asymmetrical septal hypertrophy. The septum becomes hypertrophied, and sometimes it can lead problems with the obstructive, or it causes obstruction to the outflow. So, and it is very transient. It will definitely disappear because as the glycogen stores goes down, the insulin level goes down, then automatically this thing will come down. So I hope you have to be very clear. Not that gestation diabetes in gestation diabetes it doesn't cause this thing to go up. And also maybe what HbA1c also may not be very helpful in gestational diabetes, but HbA1c levels more than 9 is a very cautious thing for you to look for a fetal anomaly to be developed. So there are various things. This is for you to just to know at your level that the pre-gestation diabetes will lead on to congenital anomalies, whereas gestation diabetes will lead on to metabolic and hypertrophic cardiomyopathy, asymmetrical septal cardiomyopathy. Right. Okay.
Absolutely.
Yes, yeah, please.
I think, Dr. Tinkle, suppose your response was good. Somebody may ask that, suppose mother is suffering from SLE. Do you expect any effect on the baby?
Congenital heart block.
Okay.
Yes, correct. Yeah.
Congenital heart block.
Can you identify yourself, please? I want to give the credit.
Kindly rename your mobile name in actual name, please.
Okay. Yeah, please. Anyway, I will ask the question in some other way. That and here this was the story. I received long back the phone call from one of my friends that his daughter at US was pregnant and detected the hydrospitalis. On investigations, they could not get any cause, but ultimately it turned out to be, as I will say, SLE. How can you explain? Did you get my question, Dr. Hardee?
Sir, it can be because of heart failure due to heart block.
Anyway, what I wanted to convey, actually that lady was not known for the SLE during the pregnancy. But during pregnancy, they faced the problem of hydrospitalis. On working up, after excluding the common reasons for the hydrospitalis, they came to know on investigation that mother was suffering from SLE. May not be having the all, I will say, obvious features. So these are the uncommon, but anyway, hydrospitalis may be the short note for you in the MD examination. There are so many other reasons which you should know. Anyway, I think we are running slowly, but I will say many details we have taken. Dr. Hardee, I think now we can share the PPT and complete the history part, and then we can focus for rest of the half an hour or so.
Okay. So natal history. At 27 weeks plus 5 days of gestational age, mother presented
Yes, carry on.
mother presented to hospital with complaint of bleeding for vaginal and pain since 2 hours. 1 dose of steroid dexamethasone was given 1 hour before delivery. Duration of labor was 4 hours with short stage 2 of labor. In view of antepartum hemorrhage, she underwent vaginal delivery. Preterm baby boy was delivered at 8:49 p.m. Baby did not cry immediately after birth, was not breathing well, hence baby was intubated and bag and tube ventilation was given. Course in NICU
Okay.
as baby.
No, before that, yeah, before we go to the course in NICU, right? Yeah. So here, so what did you think? I mean, the mother comes with bleeding per vaginum. What would be your diagnosis?
What were the
And what is the
possibilities?
impact of that on the fetus?
Fetus.
So there was a short history of bleeding per vaginum. So it can be abruptio placenta or it can be
Yes.
placenta previa, low-flying placenta that went unnoticed in first 2 trimesters.
Are they
So
out of
you
these
say
two? Out of these two, can you consider which one is more possible? Abruptio placenta or placenta previa?
Sir, abruptio placenta is
Why? Why?
more likely.
Why?
Sir, because it is generally short-lasting catastrophic. Placenta
No,
previa
no. Dr. Hardee, we were taught you the obstetric also. I'm sure that if you recollect, abruptio placenta will be bleeding with pain. Placenta previa with is simply profuse bleeding. Pain may not be there. And out of these two, immediate impact or problem will be more with the abruptio placenta. Right? Anyway, sir, you can take it, Dr. Prakash, please.
Yes, yeah. So, yeah, what will be the impact of this
On the
on the
baby.
fetus if there is bleeding? What will be that impact on the fetus?
There will be perinatal asphyxia or perinatal
Asphyxia,
depression.
yes. Perinatal asphyxia. Anything else?
Sir,
Because there's bleeding, so directly you'll.
Yeah, due to direct bleeding.
neonatal, there will be neonatal anemia.
Anemia and so what anemia can lead to what at birth?
Hypovolemic shock.
Hypovolemic shock. So whenever they ask about bleeding, 3 things you need to look at.
Very good, very good. I will say,
Baby,
I think Dr. Prakash, we should appreciate her.
Yes, I think it is very good. Nice. So 3 things you actually hit everything. So one asphyxia, second is anemia, third is in fact, hypovolemic shock, and then anemia would be the positive. Now, short thing about steroid and steroid has been started. So
Yes,
what other things should have been started to improve the
sir,
baby's outcome?
sir, we should start magnesium sulfate infusion.
Excellent. So what is the use of starting magnesium sulfate?
Sir, it will improve neurological outcome of the baby.
Okay. And how does it improve neurological outcome?
What is the mechanism?
No, already you hit this thing. Don't worry. Even if you say that, will be great. Yeah.
Definitely. Definitely. How the magnesium sulfate helps for improvement of this neurological outcome of the baby? How it works?
Anyone else?
Anyone, anybody.
Other than
please.
Hardee, we have 53 participants, right? Including experts.
So basically, magnesium sulfate primarily reduces the incidence of intraventricular hemorrhage by unknown mechanisms. And also, somebody's answered that it also reduces the activation of certain receptors and there are a lot of unknown mechanisms. Actually, it was accidentally found when they started treating for PIH and for eclampsia and other things. They actually found those babies actually had a better neurodevelopmental outcome. That's how they realized that magnesium sulfate was helpful. Now here, what would be the the delivery management in these babies? So what all you do to improve the outcomes in babies who are born at the time of delivery? What all things will you discuss with the obstetrician and try to do during the time of delivery to improve the, neonatal outcomes.
The baby is extremely preterm, so we'll prepare the labor room accordingly. If we'll check with the obstetrician for any other comorbidities, and we'll discuss the cord management plan. Because in extremely preterm, we'll use, after the baby is born, we'll use thermal wraps to prevent hypothermia. Resuscitation, we can use oxygen 30%.
So during resuscitation, do you use anything specific to prevent hypothermia?
Sir, plastic wraps, I told.
Excellent.
Plastic wraps.
Good. Can you make some comment, Dr. Hardee, on cord clamping in this baby? Because usually we recommend the delayed cord clamping, but what you should do in this situation?
So initially, when the baby is born, we'll deliver the baby on mother's abdomen. But if there is no cry, probably there would be hypothermia.
No, I think in this situation, because you have described it very nicely, that baby didn't cry immediately after birth, was not breathing well. Now in such a baby, how will you manage the cord clamping?
So we'll do immediate cord clamping.
Yeah. So I think
for fast resuscitation.
Yeah. So I think that point should be clarified, that why we are going for this immediate cord clamping in this situation, otherwise delayed. What are the benefits here? What is the risk? And therefore we go for like this. So these points are very important. Anything, Dr. Prakash, or should we go further?
Yes. So primarily you manage the hypothermia. That's one important. Cord blood management.
Yeah.
So one thing you should not do in these babies when you're doing the umbilical cord management. So milking should not be done. So just for want of time, we will just proceed. Second is you take care of the the respiratory part. Anything that you would do, preferably in the delivery room. The baby develops respiratory distress, distress.
So initially because there was no cry, so we had to give PPV, positive
No, that's
pressure
right. So if the
ventilation.
baby has a respiratory distress, these are all, why I'm insisting is these are all scientifically evident that there's a definite benefit.
Yes.
That's why I want you all to know and implement. So that's why I'm just taking a little bit of time. Yes. So what intervention you can do in the delivery room which will really impact the neonatal outcome?
What is your primary goal for the lungs?
Respiration
and establishment.
Surfactant.
Okay, the surfactant actually, that's
before that.
Before that.
And the delivery room surfactant, we don't usually encourage unless it is so difficult to ventilate.
Yes.
Otherwise, need not. We'll come to that. Yeah, somebody has already answered. Zoom user.
Delivery room CPAP.
And many of them are answering. So delivery room CPAP. Please remember that you should have the thing there. Would you know how to? Any idea about the oxygen? What if I were to you start off in babies who are preterm? How much will you start in a term and a preterm?
So in term, we will start with 21%. The newer recommendation says that we can, for extreme preterm like this, we can start with 30%.
Okay, so you can start with 30%, which will go well with, otherwise it is 32, and more than 32, less than 32, and less than 32, you start with higher, more than equal to 30, whereas in less than 32 to 35, we can use 21 to 30%, somewhere between 21 to 30%. Yeah.
Yes.
Okay. So there are so many things, but anyway, we'll consider on the further aspect of it. Yeah.
Yes.
Thank you.
Hardee, you can take it further. We'll have to look at the time also. So, but I'm sure that so many points have been highlighted, brought to our notice by Dr. Prakash, and I think very important in the management of such babies. Please take it further.
As baby did not cry immediately after birth, had breathing difficulty, oral tube was inserted and shifted to NICU and kept in incubator. Baby received medication via the tube for lung expansion. Baby was put on ventilator. Tubes were inserted into the umbilicus to give medication. Mother had given colostrum on day 1 of life. In evening, mother was informed that baby's heart was not functioning well and BP was reducing. So special medications to maintain blood pressure were started. USG of the brain was done, that was reported normal. A 2D echo was done that showed small hole in the heart. Relatives were explained that it will close by itself and no intervention was needed at present. On third day of life, baby developed jaundice. For that, phototherapy was given for 24 hours. After 1 week of birth, baby was weaned off ventilator and put on machine via nasal mask, so probably CPAP. Patient was weaned from incubator and put into warmer. KMC was started. After 5 days, baby was kept on room air, but as baby was not taking.
Just a few questions in the till now what you have gone through. Just go back 2 slides. Yeah, to
previous 2 slides.
Go back. Yeah. So Dr. Hardee, yeah, I think you had actually covered the history actually beautifully. Like.
Dr. Prakash, can you use your mic properly because your voice is not loud enough?
Better now?
Yeah.
Is it better now?
Yeah, better.
Better
Sure.
now?
Yes.
Sorry for that. Yeah, sorry.
Yes.
So actually the history, has been depicted nicely and it clearly comes across, mother has given the history and not from the case records. That's good. It's very impressive. Now, the thing here is, so what is that you are, inferring from this part of it till now, because these are all interventions has been done. Now, can you classify it and how is it going to, what are things you will look in the history later on also? What all has been done in the first 5, because the first 5 days intervention does affect the long-term outcome. So what are the first 5 days interventions you would, which is highlighted in this or which you would highlight in this, and then tell me what you would look for later on.
So baby was shifted to ICU and kept in incubators. So in extreme preterms and less than 32 week gestational babies, we generally keep the baby in incubator to smoothen the transition from in utero.
I mean, good you are telling this. I just want, because of want of time, I'm sorry, I'm interrupting you further. So, no, I just want specific point, like, this is there. I would like to look at this in the long term. Like, for example, asphyxia is there. So, there would be adverse neurodevelopmental outcome. Like that, can you point out each one of it and what is the complication you would expect?
Just
you go through each point and tell me. So intubation.
So we had to intubate and give surfactants. So it could eventually improve so it would prevent BPD in the baby. Umbilical.
So just for kind information, surfactant does not reduce the incidence of BPD.
Yeah.
Okay, so that is something that all of you should remember. Surfactant reduces the incidence of pneumothorax. Okay, and it helps in probably weaning the baby and coming down on oxygen, but it is still not impacted the incidence of or reduce incidence of BPD. All right. So it is very attractive or very logical to think like that, but it doesn't. Okay. The next in the allow ventilation, what are the problems you'll expect? The baby is ventilated. What are the problems you asphyxia? You relate long-term adverse outcome. And other thing related to asphyxia or brain development, what is there in your first slide? What other thing which happens in the first few days of life can affect the long-term outcome?
IVH can occur, which will lead to
IVH. Excellent. So IVH. So that is not there. That's good. So next is regarding the lung part of it. What are the complications for the lung? It can happen because of ventilating the lung. What problem can happen?
Can so there will be we can induce sepsis, idiogenic infections can
Okay.
occur.
Okay, infection risk is there, so you will look for it. Then, what are the effect of ventilation or long-term problems of ventilation?
BPD, but below.
Yeah, so you get bronchopleural dysplasia as the complication. We expect whenever a baby is ventilated. So that's why what mode of ventilation is known to reduce BPD. Which mode? Sorry? Volume control, you said? Yeah. So it's not volume control. Basically, it is volume targeted or volume guaranteed. I think I'm not sure whether it's time to really explain what is volume controlled. And volume controlled is it keeps delivering the volume till the volume is delivered, but does not worry about the pressure or the inspiratory time. Whereas in volume guaranteed mode, it targets the volume within the pressure breath. So it delivers the pressure, looks at volume delivered, and keeps adjusting the pressure till it achieves that tidal volume. Anyway, we'll go on to that.
Yeah.
So here explanation is done earlier and PDA, and what other thing which will have long-term implication in your first slide.
Sir, we have colostrum was given on first day of life, so it will improve
Yes,
the
very
immunity.
good. So colostrum, yes.
Why we are in hurry to give the colostrum? Somebody is going to ask the question. So how it helps, Dr. Hardee?
Why do you want to give colostrum so early is the question.
Sir, it reduces the risk of NEC also.
Yeah, NEC, and it has a trend towards reducing the infection rate. And in fact, especially on a ventilated baby, they are thinking that it should reduce even the ventilator-associated pneumonias. Right?
So Hardee, early colostrum is oral immunotherapy.
Yeah.
So it has it coats the oral mucosa. Secretion of the enzymes are there.
Yeah.
Right?
Even
there are many benefits. We can this webinar will be short of time to describe the benefits of OIT, oral immunotherapy. You should go through that. It has immense benefit.
Even somebody is going to ask the question is why or need that what is the first oral immunological component which is given, not the exact vaccine, but works like vaccine. And that is the main purpose. Then naturally prevent the infection, NEC, everything is right.
So what other thing you have in this history to say adverse neurodevelopmental outcome? Because you'll have to at the end counsel the parent, right? So what is the other thing?
So there was the baby had signs of shock.
Shock, excellent. So signs of shock is other thing. So can you tell me some other parameters which can affect adverse neurodevelopmental outcome you will seek in the history? What are the other problems are happening in the neonatal period or in the preterm period which will affect the long-term outcome that you will seek in the history?
There is jaundice.
Other than what you have mentioned, don't have very good jaundice because it is preterms are at a very low threshold to develop kernicterus. Then
yes. So there is we have given invasive ventilation, so it can lead to ROP.
All those what has been mentioned. Can you mention anything other than what is there? So one is jaundice you mentioned. Anything else which you'll seek in the history? What other thing can cause? Any metabolic can cause?
Hypoglycemia, seizures.
Yeah, so you have to cause there hypoglycemia. Yes, excellent.
Hypocalcemia.
Seizures, hypocalcemia. Right? So all these
there
things
is
are any. Yeah, go on.
Sir, if there is any history of hypothermia, all of these can
So when you,
worsen the
is a
outcome.
quick question that can you say what can lead
Again,
hypothermia onto the outcome?
Again, Dr. Prakash, your mic should be adjusted.
Sir, okay, is it better now?
Yeah, because in between it goes
I
away.
think the signal, I think I'm actually on a phone internet.
Yes,
So
yes, I
probably
understand.
net
I
is also
understand,
very
but still,
confused.
yeah.
No, so I'm sorry about it. Yeah, okay.
No, it's all right.
Yeah. So when what was the question I was asking just now?
Sir, any other that will lead to adverse neurological outcome?
Yeah. So one is, you said hypocalcemia, seizures. Hypocalcemia as such, many times it is benign if it is a late onset hypocalcemia. But seizures has got impact. Your hypoglycemia will have impact on the, neurodevelopmental, outcomes. And hypothermia, sorry, we are touching upon hypothermia. Any relation to hypothermia and mortality?
Yes.
Because, I'm sorry to take some time in this because these are all simple measures you all should learn that it impacts, though it will look as though it is not important, but it has got a large impact on the neonatal outcome. So, so can you tell me something about hypothermia?
So, even if a single episode of hypothermia increases the mortality of neonates.
Yeah. So, very good. So basically, you all have to understand the admission hypothermia or the hypothermia developing later does got definite association with mortality. So you have to take all the measures to, maintain temperature and go on. So another developmentally supportive care. Okay, you will go on. Go on to the next slide. You can start presenting. Yeah. Yeah, KMC was initiated. So can you tell me something about KMC?
So kangaroo mother care. So it will improve neurological outcome. It will reduce the
Now,
chances
what
of
is kangaroo? What are the components of kangaroo mother care?
Okay. So sir, there is skin to skin contact. There is exclusive breastfeeding.
Exclusive breastfeeding. Very good. Okay.
Somebody put very nice, the three components. What are the three components? Skin to skin, breastfeeding, and
early discharge
and follow.
And follow.
Okay.
Okay. Then
Uh,
yeah, to talk about KMC. When will you initiate? How long will you give?
So we can initiate KMC as soon as possible. So the minimum time, 8 hours per day is the minimum that we should give to improve outcomes. But
No,
it can be
baby
given
would
to
have, when you would have started the KMC on this baby?
So we have started once the baby was put on CPAP.
Okay. So, is there any gestational age cutoff you follow, or you provide KMC for even a 27-weeker, 26-weeker, and things like that?
So if the baby is hemodynamically stable and there is no signs of shock or respiratory distress, we can put the baby in KMC. We can give RT feeding via KMC. Even IV fluid can be given while the baby is on KMC.
Yeah. Excellent. So actually, the good you are providing that so early, at least 28 weeks, we should have started on KMC. If the baby is reasonably stable, even on in a stable ventilator or CPAP setting or on IV fluids and other things. So that is the one of simple measures which we can do from our side to improve the outcome. Okay. So yeah, go on. Yeah.
After 5
yes,
days.
I think hardly already we have crossed the time. So, but good discussion is going on, and Dr. Prakash is, I will say, pointing out very good points, which are not under, I will say, only PG, but everybody should remember for the practice. Yes, Dr. Prakash, can you take it further? I will say with keeping in mind the time factor.
Yeah, you can probably a little, we can move a little faster, sir, so that just complete the.
Yes.
Yeah, please go on. Yeah.
So 2D
Yeah,
was
Dr.
done.
Hardee.
2D echo was done that showed small hole and heart. Relatives were explained that no intervention was needed. On third day of diet,
So probable, what is it? Probable it is?
so
Probably what
probably
is?
PDA, sir. Patent
So
ductus
probably
arteriosus.
PDA. Yeah, okay. Yeah, okay.
So on
Next,
third day
yeah,
of
jaundice you have told. Okay.
jaundice. So at 1 week, patient was weaned off the ventilator and put on CPAP and KMC was started. After 5 days, baby was kept on
Okay.
room air, but as baby was not taking breathings well, there was episodes of apnea, so again was kept on mechanical ventilator via CPAP. A repeat 2D echo was done that showed that the PDA was persistent, and so oral medication was started to close it for 3 days. Blood investigation was sent that was
Okay.
suggestive of
So some
infection, so
medication
antibiotics
was
were
aid
started.
to, okay, sorry, well, some medication was given, right? So what is the,
Yes, sir. Sir, it is
yeah,
paracetamol.
somebody has mentioned the patent for amino. Yes, I think that from history, it may be VSD, VSG, PFO, anything is possible because it's mentioning as whole, we agree to that. But because it's preterm and other things are there, so probably with the
PDA is likely.
PDA would make a difference in the management also. Once we have the some medication was given for to aid breathing. What is that?
Sir, it is caffeine, sir.
Caffeine. So do you know any trial related to caffeine which is very famous? Okay, so all of you must read CAP trial. Okay, CAP trial, caffeine in apnea of prematurity. So CAP trial is something that everybody should be aware of because that is where all these caffeine recommendations have come out. Okay, so caffeine, do you start routinely or only when the baby is developing apnea?
Is there any role of prophylactic this caffeine? What sir wants to know? Or you will start it only on the development of apnea?
So we prophylactically should start caffeine because it will improve neurological outcome as well and prevent apnea.
Yeah, right. Correct. So at present you can start on
and it
prophylactic
also has role of
for babies less than
so less than 32 weeks.
Okay. So what is the what are any other preventive measures which can help in during this period which you are aware of in the initial period, and what are the things, what are preventive measures which will be taken up? Can you mention some of the preventive measures taken to prevent certain
problems or
avoid certain complications?
We'll do screening USC cranium to early detect intraventricular hemorrhage, or we'll maintain strict asepsis to prevent or late onset sepsis, most probably iatrogenic sepsis.
Sorry. Any IVH which you would like to avoid? What are the measures you will take to avoid IVH?
So we'll avoid frequent suctioning and loud noise.
So there's something called IVH. So you need to actually go through that. What is actually IVH bundle is? Okay, so there are set of things which you need to do. Keep the head up, midline, and sudden change in pressures, what you have mentioned, fluctuations in the blood pressure and other things. Okay, good. Any other prophylactic measures?
So because it is extreme we can start with calcium.
Okay, so the calcium will start for preventing metabolic bone disease. Yeah,
yes.
Then? Is there any, what is it, anything to prevent NEC?
We start enteral feeds.
Which type of enteral feed? Specifically name. What will it called?
Which you will try to avoid.
So we'll give mothers express breast milk. Will avoid formulations.
Yeah, excellent. So mom will definitely avoid mother's own milk,
And the small amount of that mother milk given, it is called, what is called? Any type of feed. What suffix you put before
Trophic
that
feeds.
feed? Yes.
Trophic feeds. Yeah. Okay. So any other medicine you will start? Maybe yeah. Not call it as exactly medicine, but yeah, anything you will start to prevent NEC?
So we can give probiotics.
Excellent. So you can give probiotics, but it's not uniform across because of so many
Whether
other
the probiotics uniformly recommended, Dr. Prakash?
Yeah, actually, we presently, yes, a lot of evidence are favoring probiotic. In fact, they are saying we should not conduct a trial on probiotics with the placebo. You
Sir,
can
I would
compare
like
different
to make
kinds
a
of
comment for
antibiotics.
that.
Dr.
I would like,
Shwetal.
yes, the probiotics, yes, there are lot many research and that, but the facility who has the mother's milk bank should not go with the probiotics. Early pasteurized mother PDHM can help in combating the NEC. So when you have a mother's milk, the human milk bank, I think routine use of probiotics is not recommended in the nursery. Otherwise, those who are using formula milk for the preterm babies, I think the probiotic usage is more recommended in that settings, because all this research done for the probiotics are not, so the institute were not having human milk bank. So we can go further details in the detailed study also.
That's what I said. There are a lot of
Yes.
I think this is
Yes.
one of the topics in neonatology of the debate.
Yes, sir. Yes, there is a
also, like,
controversy. I am
the only
sharing the
concern with
experience,
the
sir.
pasteurized donor milk is that they may not have those factors which will prevent NEC. So that's one of the problem. If it is mother's own milk, it has a lot of factors which it will prevent NEC. So like, and lot of subgroup analysis with excluding the formula also has shown, but I think there's a lot of controversies in it. So it is just for your knowledge
True, sir.
that these all things are available.
Yes. So this is a debatable topic, definitely. But sir, I am sharing my experience. We have
Yes,
milk
yes.
bank since last 5 years, and it is the first NQAS certified milk bank of across the country.
Oh,
And
many
our
congratulations, ma'am.
thank you. Our own data says the rate of NEC I have gone down like it's a major changes there. We do not use probiotics. Yes, definitely we need a randomized control trial and very detailed studies also.
Actually, the antenatal steroids coverage has improved dramatically.
Yes, yes,
And
that is
that
also one
also
of the contributory
reduces
factors.
NEC.
True,
Yeah,
true.
so I think
It's a
just for the
multifactorial.
students' understanding of if they ask,
Yes.
they should know that probiotics should not be missed.
Yes, yes.
Okay.
I think for the want of time,
go on.
now we'll have to take it, Dr.
Yes.
Hardee, because so many points, but I think our aim is not to just complete the case, but so many interesting and very important points have been brought out. Though I'm sure that is our purpose is served. So can you take it further?
Blood investigations were done suggestive of infection, so antibiotic was started, given for a total of 7 days. EBM via tube was continued throughout, and gradually quantity was increased. 1 week later, baby looked pale, had multiple episodes of vomiting, oxygen saturation was falling. So repeat blood investigations were done that was suggestive of low hemoglobin, and so 1 unit of PCV was transfused. Screening for vision, that is ROP, was done that had no need of intervention at present but required follow-up. Baby was gradually weaned off CPAP by cycling and put on room air at around 5th week of life. KS feeding trial was given and increased as baby was taking well. Supplementations were added. So currently, baby is taking feed via KS followed by RT, and breastfeeding trials have given. Non-nutritive sucking is being done. KMC is continued, and total 10 hours per day she is giving, and baby is gaining weight well and reached weight of more than 1 kg. Family history. There is non-consanguineous marriage, previous 2 female child, 5 years and 8 years old. There is no history of any abortion, no history of infant death. There is no history of any genetic disease in the family. Both the previous child were full term and appropriate for gestational age and good birth weight. Summary,
Yes, Your
40.
Honor.
Yes, Hardee, take it further.
Sorry, yeah, go on. So when will you screen for ROP?
Yeah.
So usually at 21 days of life or 34 weeks, whichever is later, we'll screen them.
I think just one line is very important. All the senior friends, those who are practicing neonatology is known, but please never miss the ROP. Never miss the vitamin K. These are the certain things, very basics, as Dr. Prakash was discussing, but somehow it is overlooked or not managed. And by chance, suppose baby develop the problem, there is a court of law, we are in the big trouble. So I think that's just to draw the attention of everybody that this is very, very important aspects, because now so many young, I will say, with the preterm babies are surviving, and associated the problems and complications really developing, and then many friends are in trouble. So ROP, at what time it is to be done, what are the indications, how will you do, how you can prevent, so all the aspects. And therefore, probably frequently these questions are also asked in the theory and even in the Viva also. Okay, Hardee, anything else now?
Sir, one point I want to make.
Yes, please.
Hardee, for this patient, which is 27 weeker, the protocol or the guideline for ROP is that we should first screen should be done after within 2 weeks, like any less than 30 weeker, we have to do screen early. So even if the baby is in NICU, you have to call the retinal specialist to screen for the ROP at the second week of after completing the second week of life, because they can have a progressive ROP and we can the major disability can happen. So we should screen early for the babies who are less than 30 weeker. Okay. Rest what you said, 4 weeks is a protocol for the more than 30 weeker babies. Okay, so you must read ROP protocols and what are the different zones and how we have to counsel the patient. Counseling of the parents is very important for the ROP screening. The parents must understand in a local language. Okay, so that the follow-up is ensured.
And even document on your discharge summary. Documentation is very important. Just your talk, explanation is not sufficient. Please.
A 47-day-old male child born to third Dravida mother delivered at extreme preterm by vaginal delivery in view of preterm labor and bleeding PV with birth weight of 968 grams, admitted in NICU with history of perinatal asphyxia, severe respiratory distress requiring surfactant and invasive mechanical ventilation with some congenital heart disease, probably PDA, then developed neonatal jaundice requiring phototherapy, later developed late onset neonatal sepsis. Baby had multiple episodes of apnea for which patient was kept on CPAP again and later developed anemia that required 1 unit of PCV. Currently, baby is on Kotori spoon feeding and gaining weight well.
Right. I think, just you can go through this examination and you can complete it, please.
Okay. I had examined the baby in proper.
But I think before you go further, let me draw the attention of everybody. The history part is really described very nicely, narrated so appropriately, and even most of the, I will say, problems for preterm baby has been mentioned in details, very appropriately, I will say, managed, and even competently outcome is seen. So this is really, it's very good lesson, I will say, for all of us, that how best efficiently you can manage such babies. And most of the, I will say, complications already have been discussed very nicely by Dr. Prakash and other faculties. Now we can just go for the examination and let us try to wind up. Okay.
The baby is kept under a servo-controlled warmer, temperature probe attached on the right lower part of the chest, saturation probe attached on the right hand, and baby is on room air.
I think, Dr. Hardee, sorry, it just reminded me because you said that the baby was kept under the servo control warmer. Initially, you said baby was kept in incubator. Was it
Yes,
right?
sir. Yes,
And nowadays, you know that somebody is going to ask the person like me that now we don't recommend or use even the incubator specifically. Then what are the situations in your nursery where you use the incubator? Because now I think very few situations will be there. So this question is going to be there, right?
Sir, in babies who are less than or 32 week or less than 1
Right.
grams, we use incubators.
Right. Anyway, I think I may not go in the details, but nowadays probably incubator is not much in use. The persons like we purchased long back, now when people are not available to take it, but still very few situations are there where you are going to use the incubator. And that's why probably we should know it very appropriately. Okay, take it further.
See, what is the when you're presenting, because now you're presenting to a set of doctors, so you can directly say temperature attached to the right hypochondrium. I mean, in the this thing, so you don't have to really mention right lower part of the chest then. And actually, we don't attach it to the right lower part of the chest, right? So, am I audible? Hello.
Yes, yes, you are audible. Yes,
Yeah,
yes,
okay.
very clear.
So we don't attach to the in lower part of the chest. We actually attach it to the hypochondrium.
Yes.
Because if you attach it to the bone, then you will not sense the temperature.
Yeah.
Yes.
Okay, so that's it. Okay, fine. Anything? Can you highlight the positive findings and specifically in relation to this baby so that we can move on to the.
Vitally the baby is stable. Anthropometry wise, the current weight suggests the weight is less than third centile, length is less than third centile, and head circumference is also less than third centile. So baby has extrauterine growth retardation.
I think which chart you have used here?
So we have used Fenton preterm growth chart.
Yeah, so better to I will say mention because everybody may not be knowing, and specifically for the exam, somebody is going to ask this question: what is the specific charts for these babies? Your various charts for the various conditions. Anyway, for point of time, we may not go into detail. Just I draw attention. Okay, next.
Sir, in head-to-toe examination, there is no swelling overhead. Anterior fontanelle is open. There is no facial dysmorphism. There is red reflex is normal. There is no other facial abnormalities. There is no other abnormalities in the limb, in the trunk. There is no polydactyly. And bilateral
Just
hip
present the
examination.
positive findings, and we will once we finish that, then we will ask specifically anything you look for. Yeah. Anything positive?
Anything in the respiratory system?
No, sir. Respiratory system is normal. Cardiovascular system is
Whether
also
the
normal.
respiration rate is normal?
Sir, so there is a little bit of periodic breathing. That is why it is intermittent. But
Okay.
it's not.
At least not the specific significant tachypnea.
Yes, sir.
Okay.
In CNS, sir, cranial nerve examination is normal. On tone, there is increased range of movement, sir. So, scarf sign is elbow crosses the midline. The adductor angle is 160 degree. Ankle dorsiflexion is 20 degree, and popliteal angle is 150 degree. So there is some hypotonia.
Hypotonia.
Yes, sir. Otherwise,
but
on
generally,
active.
these angles are not meant to be measured in this age group, right? So it's. Are you talking about Hamilton angles here, or you're talking about any other angles?
Sir, these are Emil Tyson angles.
Yeah, Hamilton. I'm not sure whether it starts so early. It usually is applied only from later part, after term gestation.
Yeah, I think
so. If you have to apply
particularly.
a neurological examination, which one will you do in a neonate?
Sir, we have done neonatal reflexes. In this, rooting is present, sucking is fair up till now, glabellar tap is present, palmar and plantar reflex is present, ATNR is absent, and morose is incomplete but bilaterally symmetrical.
Okay. And what do you mean by do you know any other named examination in neonate which you can perform at birth at term equivalent age?
So we can do HNNE.
Excellent. What is HNNE? Because just for others to understand, what is it?
Yeah.
Sir, neurological.
Okay, Hammersmith. Okay,
Hammersmith
neonatal
neonatal neurological
examination. Excellent. Okay, right. Good. Yeah. Say, go on. So you did not have any positive findings in this. So just to summarize, if you have to, look for, in growing preterms, you will basically look at, the how is the baby nutritional part of it is, and the respiratory, how is it,
Hardee,
and any other murmurs.
For you to, is there any presentation now? You have slides?
So we have chest X-ray.
Okay, I think just you can show and you can stop sharing, and then Dr. Prakash will take a few minutes for the discussion. Okay, chest X-ray, anything? What is your interpretation?
So the final diagnosis is single male, extreme preterm, 27.45 weeks, born via normal vaginal delivery, extreme low birth weight, not cried immediately after birth, requiring bag and tube ventilation, perinatal asphyxia, respiratory distress requiring surfactant, and invasive mechanical ventilation, late onset sepsis, apnea and anemia of prematurity, neonatal hyperbilirubinemia, and congenital heart disease, probably PDA.
Okay. Some comments on this. So, I mean, it's a very elaborate diagnosis.
If nothing is there, you can stop sharing.
I just want this to be displayed, sir.
Okay. Yes,
so,
sir, please.
So now, see, in the diagnosis, you have to stick to something called, international classification of diseases. So, whatever doesn't come in this, you should try to avoid in final diagnosis, because that is important from the epidemiological point of view. So, born via normal vaginal delivery, and as such, if you write vaginal delivery or normal delivery would mean, but do not mention normal vaginal, there's no other route, one. So, born via normal vaginal will not be coming in the diagnosis. Not cried after birth is a symptom or a sign, because that also should not come. Just write the perinatal asphyxia, RDS requiring surfactant. Maybe you just want to mention that, and then respiratory failure. And remember, PDA is not a congenital heart disease. Okay, so do not classify that as, even if you look at the incidence of congenital heart disease, they would have clearly written below excluding preterm PDAs. The PDA is an inherent, a structure which is there in the preterm baby, and it doesn't close and then closes later on. So PDA is not a congenital heart disease. So don't club preterm PDA under congenital heart disease. Okay, you just say, I have to just put a diagnosis of PDA. So now, is there a murmur now, or there is no murmur now?
No, sir. Now there is no.
So you can probably say PDA and close.
So it's not the congenital heart disease.
And how sure are you it is PDA?
So the echo suggested that it was PDA.
No, why it is? Because they have given medication to close
it. You said some medicine was given for, You said some medicine was given for 3 days. That
3 days and close. So definitely it should be PDA. No other VSG or anything will not close like that. Right? So it should be PDA.
Because somebody asked you that how will you say that the patient is taking the anti-tumor therapy? You can say that the color of the urine, because rifampicin is going on. Similarly, you can say here that the medicine is given for 3 days, and later on this already somebody informed that that lesion has disappeared. I'm sure it is sufficient to say that it was the PDA, right? Like that. Okay, sir. Dr. Prakash, anything from your side?
So can you just say further management of this baby? So you should include, present post-menstrual age also in your this thing, to understand what is the present this thing. And
CGA,
EUGR,
basically.
EUGR, you should have mentioned that.
Okay.
So you should mention EUGR is because that is less than third centile, it's gone below the 10th centile. So these are some of the things you could have included potentially. And what is the management now quickly and talk about prognosis and counseling. With that, I think we should be able to wind up.
Yes, yes. I think we can take few minutes, but just we can complete all these headings.
So for another 5 more minutes. And
yes.
I thank all the participants to have been here for such a long time.
Yeah. Now, Hardee, if suppose no presentation, you can stop sharing. You have any slide now?
Yeah, you can stop sharing and just tell us what will be the further, what will you like to manage and plan discharge, and then your the prognosis.
Even prognosis and counseling.
Yeah, prognosis and counseling. Yes.
So we'll now we'll mainly focus on managing the feeding. We'll give HMF, that is human fortifiers with feeding to improve growth. We'll give supplements and
so basically, we'll target nutrition. So that will be your primary aim. Okay, good. So one is nutrition, right?
Yes.
So you try to achieve a weight of 1 to 1.5%.
1.5. So
next.
then, before neurodevelopment, we'll give early stimulation
very good. So
therapy.
neurodevelopment is the, I expected that answer to come. Excellent. Very good. So neurodevelopmental support you will be providing, though it needs a lot of time to really explain, look at what are neurodevelopmental things which can be done. Okay, next.
So we'll do one screening USG cranium at the age of 36 weeks to look for periventricular leukomalacia or anything like that. Before discharge, we'll plan for OE screening,
hearing
screening,
screen. Okay,
and vaccination.
Excellent. So vaccination, what is your policy? I think that
I think vaccination part just now we have not touched, but somebody will say whether in the nursery it should be given or not, at what time, everything. I think very big chapter, but still you can take the main principles. Yes, Dr. Prakash?
Yes. So what are vaccines you would give in this baby? In the nursery, this is 47, no? Right. Yeah. So what all things you had already given?
We're able to give only BCG because timeline for OPV and Hep B is gone.
Okay. So what if given a chance to the baby again, so what things you will do differently in the vaccination part of it?
Whether Dr. Hardee, when the baby was stable in the nursery, could have been given these vaccines? Should
no,
we
go?
Sir.
Yeah, go on. Please go.
Or what is the recommendation that which vaccines can be given the stable babies even in the nursery?
Sir, hepatitis B can be given to stable babies if they are up to 2 kgs. And OPV and BCG can be given, but there are chances of OPV transmission in the nursery series, so we generally we do not give.
Nowadays,
and what about the DTP or DTAP?
Sir, that we'll have to give 6-10.
Just a short, just for want of time. So you can give all the vaccines. BCG hepatitis B. OPV, it depends on the unit protocol. That can be avoided, but BCG and hepatitis B should be given within a week also if the baby is stable. We usually give within 3 days.
Even that hepatitis B, the 2 kg weight criteria has gone.
Actually, that is all.
It has gone.
That's all is removed. So now BCG hepatitis B in the nursery within first 72 hours itself we give if the baby is stable, and then the other things will go as per the chronological age and no, not looking at. So at 42 days, 6 weeks we will give all the vaccine.
Even one more question. Suppose the baby, as you said, 47 days. So can we give this rotavirus vaccine?
Rotavirus we give, sir. We give roti because there is a lot of evidence which says it doesn't, though it spreads to the other baby, but it doesn't cause much of a problem.
So
and
it is,
rotavirus, which goes on in the unit, is actually a different type of rotavirus.
yeah.
You all, I don't know, that's a different research altogether. There is a rotaviral, neonatal rotaviral infections, a separate thing, but that is not the one which causes disease later on.
The only thing which point I want to students to keep in mind, there are lots of, I will say, changing the recommendation that which vaccines particularly, because nowadays, you know, babies are surviving and neonatal NICU stay is very prolonged. During that time, so many vaccine comes in the schedule. And therefore, I think we should know exactly that which vaccine should be given at what time and which vaccines should be avoided. So this point should be very clear. I think for want of time, I may not go in the details, but just all of us should know. All of us should know.
So quickly on prognosis.
Sir, so if prognosis wise, we'll generally preterm, such extreme preterms will have
Hardee,
development.
sorry for interruption. Examiner is going to ask you that what prognosis you will explain for this baby. Principles of preterm baby and counseling, everything you must be knowing. Now apply these principles in counseling regarding this baby.
Sir, the prognosis for the baby is good, but there was anemia, so we'll have to look for that. We'll have to continue supplementation. We'll have to monitor the growth and supplement such that the growth should
No. When
reach.
you're talking about prognosis, what will you say? Like, mother comes and asks you the prognosis, what would be the prognosis? So what are factors you'll take into account to predict the prognosis?
Hardee, I think it's a very simple question. What the parents will ask. We stayed here according to a recommendation. Now we are discharging. We hope that now our baby is fine. Our baby is not going to develop any problem or complication and going to develop as normal. This is the expectations of the parents. Now you will have to explain that how best ultimately you are predicting or expecting. That's a prognosis. What you will say?
There will be neurodevelopmental issues.
Okay.
So, shall I just summarize probably?
Yes, sir. Yes, sir. I think Dr. Prakash, that is very important for,
yes,
and
so what
we
you
have,
need to.
we have extended very long time, but I'm sure it was worth to do it.
No, sir. I just, I
can.
thought probably Hardee is finding it difficult, so
I
thought I'll just help them to understand it. So basically, when you talk about prognosis, you have to now take out the factors which will, which will impact the long-term outcome. So here, perinatal asphyxia is there, shock is there, right? So those are two factors. But the fact the baby has, come off ventilator in 7 days and you're able to establish feeding, there's no other much of a complications. So, you have to tell them that having these two factors can impair the adverse neurodevelopmental outcome. But having said that, this baby at present is, being normal for age. I mean, the neurological examination as far as we do. So there is a high chance of this baby could have a good prognosis. And very rarely we may expect this baby. I mean, there is a possibility that this baby may develop adverse neurodevelopmental outcome. So what is that? So next thing, what will you say? After explaining this, what is the important thing you should drill into the parent's mind? So, what they will ask, what should be done? What can we do to improve the outcome? So what will you say?
Early stimulation.
Yeah, so for that, they should come for excellence. Somebody has given the answer. So you have to tell them child development follow-up. Okay, that is, apart from breastfeeding, apart from, giving KMC and all that, a regular, child development unit follow-up should be part and parcel of their receive. So, and tell them that once you identify early, a lot of the things can be improved by simple exercises and, things like that. So these are some things which you need to understand at your level to improve the neonatal part of it. Yeah.
So I think just for one of time, I just stop here. If in case
Yeah.
anything that you would like to ask for, I'm happy to answer.
Anyway, I think we'll have to end over here. First, let me really appreciate Dr. Hardee. I understand to stand before all these people after completion of only 3 years of your residency. And that too, I will say you have best presentation. You responded, I will say, very nicely to all the questions, single-handed. No, your friend has come to your help. So I think that also you should take the note of it and see, right? Of course, your, I will say, mentor was there to help you, and some of the teachers certainly. But really, I will appreciate even Dr. Prakash. And when he was, I will say, handling this whole discussion in such a, I will say, way, very informative and learning session. So I thought that I should keep the minimum interruptions from my side. I restricted myself in this way, and certainly
No, sir. I think we also gave a lot of input. Yeah.
And really, this 2 hours, our session, more than 2 hour session, little bit time certainly extended, but I thought that it is worthwhile, and therefore ultimately we have utilized these 2 hours best. And I'm sure that not only the students, but all of us learned a lot. And nowadays, you know that these types of babies are very frequently presenting to us. We should be very competent enough with even our facility, understanding is improving life. And certainly it makes difference in the outcome of such babies also. So I think we'll have to end over here. And of course, with a word of even appreciation, gratitude to Dr. Prakash, the faculty, expert, and all your other faculty. There you can see that up to beyond 11 o'clock, even midnight, I will say gradually, that they are sitting and listening to all of us. And it indicates that certainly people are interested in learning. Thank you very much. Over to you, Dr. Nehal or Dr. Lata, to take over it. Please.
Lata.
Thank you. Thank you, sir. Such a wonderful discussion. Really, it was worth. I'm in Surat, I'm for exam, but I couldn't stop it. I was just listening and listening and listening.
Yeah.
So wonderful and very good presentation by Dr. Hardee, I'll say.
Yeah.
Okay. So thank you all.
I think, I should also appreciate Dr. Hardee for a very nice and presentation, very well presented. And most of the points were there. We just have to hunt the questions to really make people learn. And thank you for the Gujarat. And I know this has been a very successful program, and a lot of people attend and get a lot of benefits out of this. I think I should thank the whole team for organizing this, and so happy and honored to be called to be part of this. And sorry if this section went very long. So we could not just cut short the discussion as expected, and in any case presentation. Yeah. Thank you so much. Thank you so much.
The pleasure is all ours. Thank you so much for being here. Thank you so much.
Thank you and good night.
Thank you.
Thank you, sir. Good night.
Thank you, sir.
Thank you, everyone.
Good
Our
night.
faculty. Good night.
Thanks, Hardee. Yeah.
You are part of the Gujarat.
Thanks. And the Gujarat mentor part of. Actually, I forgot to mention that in my. Sir, thanks for reminding. I'm actually a Gujarati by post graduation. I did the MP Shah Medical in the MP Shah Medical College, Jamnagar, and Dr. Yogesh sir was one of my mentor. Still, he is a mentor. That's a different story. And we all are, I'm very, happy and feel very gratitude, to be part of this. That I'm in this Gujarat program. And
so
I would like
next time you come here as a mentor,
more also. Very happy to get more.
Prakash.
Sir?
You come as a mentor and with your student.
Sure, sir. Sure, sir.
Okay.
So different.
Thank you. Thanks, Prakash.
Still, we are here 50 people, and there's that Bala Subramanian sir and Siddharth Ramji sir program. There's the 65 people. So what are the love and affection for the Gurukul?
Thank you very much, all of you. Again,
thank you so much.
And good night.
Good night. Good night.
Thank you, everyone. Good night. Good night.
Good night, everyone.